Hello, everybody, and welcome back to my YouTube channel after some times. And today we will discuss a very interesting topic, which we usually ignore in our practice. That is gram-positive sepsis. I was asked to give a talk about this topic in a conference, oncology conference in Kerala, and luckily they have a critical care segment. And that's good to see that oncology division has recognizing the contribution of critical care for that subgroup of patients also. So my topic was salvage antibiotics for gram-positive septicemia in neutropenic patients. I had no conflict of interest. So I'll start with a case. A 50 years old lady had myelodysplastic syndrome with secondary acute myeloid leukemia. She received post-chemotherapy, and after that, on day 10, she was admitted in ward with fever and total leukocyte count of 200. She is also having shortness of breath, diarrhea, abdominal distension, and mucositis. She had a peak in C2, which is around day 28. So the medical management continued along with appropriate antibiotic as per our hospital protocol. In our protocol, we start with piperacillin, tazobactam, and amikacin for neutropenic fever. So on day 4, she was shifted to ICU with worsening shortness of breath and hemodynamic instability. And on day 5, microbiology team has updated us that the blood culture is positive. So there are clinical dilemmas like any other antibiotic prophylaxis should have been given, though we do not practice any prophylaxis, whatever we have given as an empirical therapy. If we consider to give prophylaxis, what are the bugs we should cover? Should we add gram-positive cover to the empirical therapy? The point is that whether piperacillin, tazobactam, and amikacin do have any gram-positive cover. If yes, we should add some more gram-positive cover, then why? And what to cover? And if not, then why not? If you look at the guidelines by 2014 updated guidelines by the German Society of Hematology and Medical Oncology, they identified what the bugs that can cause neutropenic sepsis. And I will focus only on the gram-positive bugs. So if the source is unknown, there's a systemic infection may be presented with hemodynamic instability. It can be coagulase negative staph or enterococcus. For pneumonia, most common organisms are Streptococcus pneumoniae or viridin streptococci, that is the alpha hemolytic streptococci. For abdominal sepsis, enterococcus is most common. For skin soft tissue, it is the Staphylococcus aureus and alpha hemolytic streptococcus. And for central and acidic infection, it is mostly coagulase negative staph. So if we divide those bugs, we are going to deal with Streptococcus viridans, Streptococcus pneumoniae, Staphylococcus aureus, coagulase negative staph like epidermidis, and enterococcus like fecalis and fishium. But if we try to choose antibiotics for them, then we'll found there is a varied types of drug resistance can be present in this group. Like pneumococcus can be penicillin resistant, macrolide resistant, or maybe resistant to multiple drugs, which is called drug resistant strep pneumonia, and the incidence is increasing. Staphylococcus can be methicillin susceptible or resistant, linezolid resistant, vancomycin resistant or intermediate, or maybe resistant to other glycopeptides. And we are all aware about vancomycin resistant enterococcus also, which most commonly is the fishium. Now, in terms of prophylaxis, we do not practice prophylaxis in our unit, but in some Western data has suggested for prophylaxis, it is applicable specifically for high-risk patients with a prolonged and profound neutropenia. Prolonged means more than 7 days and profound means less than 100 WB, absolute neutrophil count. And this suggested for fluoroquinolone prophylaxis, you can use levofloxacin or ciprofloxacin. Some studies show levofloxacin is preferred if the risk of oral mucositis-related viridans infection is high. A meta-analysis involving 17 trials of fluoroquinolone prophylaxis had shown that there is a relative risk reduction by 48% and 62% in case of all-cause mortality and infection-related mortality for patients who have received fluoroquinolones. And it is stronger for ciprofloxacin prophylaxis. Another study has shown that levofloxacin prophylaxis can reduce the episodes of fever, that is neutropenic fever, and also documented infection, including gram-negative infection. But we need to understand this is applicable when the risk of MDRO is very, very less and the bugs are sensitive to fluoroquinolones. In our country, it is very, very unlikely. So when we are talking about bloodstream infection, neutropenia, it can be primary BSI when the source of infection we are not very sure, and we consider then probably there is a transmigration of bacteria from the gut into the blood. It can be central and associated bloodstream infection or a secondary infection when there is a definite source present in the body as a site of infection and blood bacteria has transmigrated from there into the blood. So the secondary source can be skin and soft tissue, urinary tract, gastrointestinal tract. It can be pneumonia, osteomyelitis, endocarditis, thrombophlebitis, mastitis, or meningitis. Also in gram-positive infection, there can be toxic shock syndrome when the clinical symptoms are because of the production of toxins by the gram-positive bacteria. And in that situation, even if you give sensitive antibiotic, there may be an initial clinical failure because of the systemic effect because of the toxins. Now, when you talk about empirical antibiotic of choice in this group, these high-risk patients who require hospitalization are usually recommended to receive anti-pseudomonal beta-lactam agents like cefepime and piperacillin tazobactam or a carbapenem like meropenem and imipenem cilastatin. This is recommendation as per IDSA guideline. If there is a complication or you are suspecting or proven resistant pattern is there, then you consider to add aminoglycoside, fluoroquinolones, or vancomycin. For vancomycin or any other similar antibiotics covering resistant gram-positive bugs are not recommended routinely. And if you even start it because of the clinical condition and the cultures are negative, it is recommended to de-escalate by 48 hours. So when you are talking about the options as a rescue therapy on top of the empirical therapy that we use, and specifically for gram-positive, these are the options like vancomycin, linezolid, teicoplanin, daptomycin, and tigecycline that we are presently using in our practice. There are new molecules either has launched or about to launch in the market like ceftaroline, ceftobiprole, dalbavancin, telazolid, telavancin, and quinipristine, dalfepristine. All these molecules are not available in India at this point. The IDSA in 2011 guideline has mentioned that what antibiotic should be considered to cover different types of gram-positive bacterial resistance, like MR4, MSSA, cefazolin, and cloxacillin. Now we do not have cloxacillin in our practice, so we use flucloxacillin. For MRSA, vancomycin, daptomycin, teicoplanin, linezolid, our first choice is usually teicoplanin, and mostly because of a theoretical safety profile. We'll see what is the data suggested. And for VRE, the first line is linezolid and daptomycin in case of resistance. For case of drug-resistant strep pneumoniae, respiratory fluoroquinolones can be an option, or beta-lactam along with a combination of doxycycline. In our practice, sometimes because we try to give carbapenem to cover the gram-negative bugs, eventually it covered the drug-resistant strep pneumoniae also. Now, if you look at the data in form of empirical gram-positive cover in neutropenic fever, this is the meta-analysis which involved 13 studies and patient of 2,300, more than 2,300, and they look at empirical glycopeptide usage, specifically vancomycin. And they found there is no significant difference in all-cause mortality and overall clinical failure at the end of therapy. It is obvious that bacterial superinfections was less in the intervention arm who received empirical glycopeptides, but the adverse effect, specifically nephrotoxicity, is also more common in the glycopeptide group, with a relative risk nearly 1.88. What if we add beta-lactam aminoglycosides, as we are doing in our practice? Again, this data is not in its favor. Studies shown that this is a meta-analysis involving 46 trials of 7,600 patients, and they also got favorable data for carbapenem, specifically for carbapenem, also for other BLIs. And they found that no significant difference in mortality or treatment failure in bacterial or final superinfection in the group who received only beta-lactam compared to beta-lactam anti-aminoglycoside combination. And the adverse events are significantly more common in the combination group. That is the renal toxicity for patients who receive aminoglycoside. Even after that, we should not follow these guidelines or recommendations in a blind manner. Whenever we are choosing antibiotics, the most important information is our local antibiogram. In our hospital data, it suggests that some of the bugs which are resistant to piperacillin are sensitive to amic acid. And that way, we can cut down the usage of carbapenem, empirical usage of carbapenem in our neutropenic fever patients. And that's why we are following this protocol. But when we should strongly consider to give gram-positive cover for resistant bugs. These are the indications like gastro-related infection, skin and soft tissue infection, pneumonia, patient with hemodynamic instability, that is neutropenic sepsis with septic shock, blood culture positive for gram-positive cocci, severe mucositis, previous infection or colonization with organisms like MRSA and VRE, or if there is a high rate of endemicity. When we talk about high rate of endemicity, we usually consider the incidence of gram-positive, resistant gram-positive infection more than 10%. If you look at the epidemiology, even in the Western countries, when we know that gram-positive infections are the main load, we found that gradually the resistance to gram-positive infection is increasing. And there are studies which show that MRSA infection can be as high as 50% among the staff population. In India, because we are not anticipating these bugs to begin with, if we are failed to give empirical antibiotics in the right patients, the mortality can be high. Gram-positive infection specifically with staphylococcus in blood culture can be as high as 30%. And some of them are drug resistant, that is both MRSA and VRE, and that in ICU the incidence can be up to 15%. Recent publication, which is Eurobac study, which look at the data of 1,156 patients who are admitted in ICU with an BSI, and they found that MRSA is present in 50% of those patients, and it is independently associated with increased mortality, and that can be as high as 16%. And what are the other two gram-positive bugs, which looks apparently less important? One is coagulase negative staph. We commonly identified coagulase negative staph as a cause of bacteremia. These are weak pathogen. And if we get only single positive culture, we should consider it as a contaminant. If it's positive in repeated culture, only then we should consider as an infection. And another is viridian streptococci, which can be resistant to beta-lactam and fluoroquinolones, as I mentioned. In sick patient, neutropenic patient, it can present with a shock and adult respiratory distress syndrome. Penicillin resistance can be as high as 25%, and there is a progressive reduction in fluoroquinolones because of frequent usage of this for upper respiratory tract infection. This is a publication from our own hospital that we are share our experience and journey in terms of different kinds of bugs. And if you focus on the gram-positive part, you can also see that the incidence of MRSA and MSS has increased in terms of volume, and percentage of MRSA has increased over last few years. And also there is an increase in the glycopeptide resistant enterobacteriaceae, that is VRE, that we are talking about. So what are the resistant patterns? We need to understand a bit about the resistant pattern to decide about our empirical choice of antibiotics. For staphylococcus, it is a MAC-A or MAC-C gene, which causes an alteration in the penicillin binding protein, leading to methicillin resistance. For VRE, that is vancomycin resistant enterococcus, it is a Van gene group, which is also called Van alphabet. And there is a modification in the peptidoglycan conventional structure, and it prevents the vancomycin to bind to D-ALA precursor protein, precursor site. And it can be Van A or Van B. Van A causes resistance to both vancomycin and teicoplanin, and Van B to only vancomycin. For Enterococcus faecium, there is also additional production of penicillin binding protein 5 and causing polymorphism of the transpeptide domain. For fecalis, there is a mutation in the penicillin binding protein 4 gene. There can be lineageally resistance also because of 23SD RNA gene mutation, or can also be resistant to other oxalidoxone and tigecycline because of different mutations. Sometimes we also need to change the drug because of the toxicity or because of decreased organ function for a certain group. Like we try to avoid vancomycin if there is a renal failure, or linezolid in case of thrombocytopenia. So some important points of vancomycin related to neutropenia. The studies that show that in neutropenia, vancomycin clearance increased by 27%, so that dose should be increased by 25%, that is 1/4. though the volume of distribution is unaffected, so no need to change or adjust the loading dose. And this we have to do along with dose individualization and therapeutic drug monitoring. Why did it happen? It mostly happened because of an augmented renal clearance in neutropenic group. And this augmented renal clearance seems to be reversible when the neutropenia resolves. So the only option is that to do frequent drug therapeutic monitoring to avoid clinical failure and toxicity to maintain within the proper therapeutic zone. But when you compare with vancomycin with teicoplanin for febrile neutropenia and try to look whether vancomycin is most toxic, and present data doesn't suggest that. This is the paper, this is a meta-analysis involving 10 studies and 1600 patients. And they look at the outcome of vancomycin and teicoplanin along with toxicity. They found that both treatments are comparable in terms of treatment success, nephrotoxicity, and red band syndrome. Only the vancomycin group has a higher skin rash. What about linezolid? Should we consider to use linezolid in neutropenic patient because it's a bacteriostatic? Studies which compare the efficacy and safety of linezolid with vancomycin in randomized trial have found that outcome is reasonably comparable, along with less drug-related side effects with linezolid and less nephrotoxicity. So it can be considered to use. Thrombocytopenia can be a concern. What about TG-SAT? Should we consider to use? Because this drug we know doesn't concentrate in blood and doesn't concentrate in urine. So there are specific recommendations specifically for neutropenic enterocolitis. Because it was concentrated well in the gut, there are strong recommendations to use tigecycline-based therapy for neutropenic enterocolitis in hematology or neutropenic patients. So what is new? There are some new molecules I already discussed. I will try to cover some of them. The first is ceftaroline. It's a beta-lactam of 5th generation cephalosporin. It quickly hydrolyzed to its active from ceftaroline via plasma phosphatase. It binds to penicillin binding proteins like penicillin binding PBP2A and 1, 2, and 3. It affects the cross-linkage of peptidoglycan chains that weaken the bacterial cell wall and cell lysis. It acts against methicillin-resistant Staphylococcus aureus and for pneumococcus, which is resistant to penicillin. It can have some action against other respiratory, community-acquired respiratory gram-negative bugs like Haemophilus and Moraxilla, and also have some action against non-ESBL producing Enterobacterus, which is practically absent in Indian. All the Indian gram-negative bugs are ESBL produced. All the Enterobacterus are ESBL produced. And it has a very limited activity against Enterococcus, ESBL producing Enterobacterus, and non-lactose fermenters and anaerobes. So you can see literally no gram-negative, practical gram-negative cover, and no cover against Enterococcus. Clinical use, the recommendation is for community-acquired or resistant pneumonia and skin and soft tissue infection. It shows non-infectious ceftriaxone for community-acquired pneumonia and azithromycin and vancomycin. As I mentioned, it is okay for non-ESBL producing gram-negative bacteria. For bacteremic MRSA pneumonia, it's a good option because of hydrophilicity, good penetration in the alveolar lining, and lower nephrotoxicity. It may need to be added on with daptomycin for persistent MRSA bacteremia. Other off-label usage are bacteremia, endocarditis, osteoarticular infection, HAP, and meningitis. For meningitis, a standard practice is vancomycin, but when it compared with vancomycin and ceftriaxone combination in animal model, it shows that it has a good CNS penetration with probably better antimicrobial activity. But the dosage requirement is higher, both for meningitis and for endocarditis, and we should consider to give 600 milligram 3 times a day compared to twice daily. And also encephalopathy and neutropenia can be a concern for patients who are receiving it for long duration or with an adult therapy. What about PKPD? Plasma protein binding is around 20% and it's predominantly eliminated by glomerular filtration. Mean half-life is 2.6 hours. Augmented renal clearance can be a concern and may lead to subtherapeutic dosing in case of MRSA. Then you have to consider to give a higher dose. Good distribution to muscle, subcutaneous tissue, and epithelial lining. As I mentioned, for PKPD, the percentage of time is the important factor above the MIC. So that is fractional time more than MIC is the factor. And the target is that 45 to 100% based on severity of the infection and the patient's clinical condition. Next molecule is ceftobiprole. Again, it's another 5th generation cephalosporin, similar action with ceftaroline, penicillin binding protein, and inhibition of the cross-linkage of peptidoglycans and formation of bacterial cell wall leading to bacterial cell lysis and death. Again, it binds with different penicillin binding protein, but it has some little better gram-negative activity. It has action against Pseudomonas, MC, some ESBLs like TAME and HSV, not much, some Enterobacter C and anaerobes. For gram-positive infection, it combines with penicillin binding protein 2A, cover MRSA and staph epidermidis, and for staph pneumoniae, penicillin binding 2X. Ceftobiprole does not bind with penicillin binding protein 5, so no action against Enterococcus faecium. It is approved for CAP and HEF, and non-inferiority of ceftobiprole to vancomycin and azithromycin for skin soft tissue infection. Good option for endocarditis and bone and joint infection. For PKPD, it's administered by IV as a prodrug and converted by plasmaesterase. Linear PK, elimination half-life 3 hours, protein binding 16% with a volume of distribution around 20 liters. Major route of elimination is glomerular filtration, and drug clearance is reduced because of impaired renal function, so drug dose adjustment is needed. Again, augmented renal clearance is a concern, so you can give a prolonged drug infusion to avoid subtherapeutic dosing. Good penetration to muscle, adipose tissue, and epithelial lining of the lung. Lower drug concentration reported in bone tissue. So in case of bone and joint treatment, be little apprehensive. Again, it's a time-dependent antibacterial activity, and pharmacodynamic target is to keep time 60% of T more than MIC. For that dosing interval, and 90% of the population who receive the drug. So, and the last molecule which I'm going to discuss is dalbavancin. Again, it has been launched and it has been used for OPAT therapy, that is outpatient antibacterial therapy for gram-positive infection because of its prolonged half-life. It's a second-generation semi-synthetic lipoglycopeptide antibiotics. It has a long lipophilic side chain that increases the potency and half-life, tightly binds to D-ALA portion of peptidoglycan chain and prevent peptidoglycan elongation and interfering with bacterial cell wall synthesis. Bactericidal activity against gram-positive bacteria and antibiofilm activity against staphylococcus is a big advantage, but it doesn't have any action against gram-negative and does not cover binary resistance. These are the concerns, and it can have cross-resistance with other glycopeptides also. It has been approved by FDA for skin soft tissue infection. The dose is 1000 milligram loading followed by 500 milligram after 1 week, or we can give 1500 milligram single dose also. And we have data to recommend that. The second one is non-inferior compared to the interval dose. For osteomyelitis, probably you have to give a higher dose and have to repeat 1500 after day 7. Cross-hypersensitivity with other glycopeptides is a concern. It has a characterized by a terminal half-life more than 14 days and along administration either the 2 dose as I mentioned or a single dose. PK is linear, dose proportional and characterized by high protein binding. After initial distribution, drug level of plasma declined rapidly within 48 hours and the drug concentrated in the body tissue. That's why it is recommended for skin soft tissue infection. Excrete is 1/3 unchanged in the urine and 1/3 in the stool. No dose adjustment is necessary for patient with creatinine clearance more than 30 or patient who's on hemodialysis or on mild hepatic impairment. So what are the drugs in the pipeline? Like otrivamcin, omadacycline, texazolide, and dalafloxacin of different groups, like some of the tetracycline, some are fluoroquinolones. And also there are a lot of other drugs which are in phase 2 and phase 3 trials. So I think in coming days, we'll have some more molecules which are safer compared to the prototype drug of vancomycin and can be used for increasing gram-resistant infection. I would like to conclude my presentation. Thank you.